Good evening, everyone. 24-year-old female Chiri comes to OPD with complaints of her right knee pain since 2 months. She doesn't have any other complaints. Range of spine. She doesn't have any knee stiffness, any no constitutional symptoms, no fever, no other complaints. Then we go ahead and evaluate her. We get her results. So ask her, is it B and wicked brain lesion, ciliary lesion, PT 4 years, TCT first. Celluloid devices and the marginal marginal cortex is not reached. Yes. You are ready for it. Let's start DCT was again I felt about DCT the air demons like the CL of it was very rare. Teeth sign just catching it very rare, very it is with a very well sclerotic lesions, atrocious tuberculosis, second pass. There is a calcification is in the day. Something because inside so many things. So I have the can you get and in the Arabic has to get an X-ray. You are more at least above they're not not like these are not typical calcifications, but the leftover bone at the other side of the bone is what happens if you get the density, it is not more than the surrounding areas. If you see the density more than the remaining part of the bone, then we say it is more calcification as well. Let's say here. So, eccentric epiphyseal. So if I see it. Then comes MRI. On that right, they can straightaway say it might be easy. So this is our MRI. Anybody wants to look? In MRI, also just like any other, that people like polyths and even like current tape, they did a subpressure with single test. And okay, bone expansion, liquid bone expansion, not in all regarded to Machi. What does is occur? Yeah, adequate, not much, but not more information. That's about it, actually. Is in the podcast. Okay. Yes. In the Bhadra study, there is enhancement. So, tuberculosis to got events like this. That's got a soft tissue component, which is enhancing with polyester. So, that's a sorry cough. So, this is the enhancement here. And that is enhanced because of you, and it is hard, it is enhancement here. Enhancement is more aggressive, more solid component, or a more cellular component, sound factor. Yes, so push weight folks. Yes. Posteriorly texture soft tissues as per else. And I'll go ahead with the MRI report. It says well-marginated exceptic cancellous lesion along with perial coronal condyle, extending the subcaudal bone with parallel non-sclerotic hyperinflex match on T2. There's also bilesional marrow edema and thick periosteal reaction. And the lesion measures about 2.7 to 3 centimeter. Extending anterior posteriorly, mediolaterally, cardiopodally. Differential diagnosis, it could be long tumor, giant cell tumor, or more impacts. There is also small size similar signal intensity lesions in the proximal tibia and posterior aspect of flatter femoral condyle, measuring about less than 1 centimeter in 90-month dimension. And in the incidental finding of small cases. I like the description of the Hooper. Spittle them weakness thick. So the next step we went ahead with the biopsy. So the biopsy report says it's a granulomatous CD. So the success study, it showed multiple disrupted fragments of dead necrotic bone and marrow spaces is showing granulomatous lesion comprising areas of amorphous granular necrotic material, and it also is surrounded by aggregates of lectinoid and histiocytes, Langerhans cell, giant cells, and little trace of lymphocytes and plasma cells. No evidence of ADP or malignancy in the sexual state. Portlet irreversibility biopsy. Ela correct really this will say it is a difficulty after sclerotary biopsy report after removing everything. No. That's biopsy. So that is a biopsy report. Right? Say what biopsy? Not to see. Till put it as says a necrotizing granulomatous primary lesion likely to be a tubercular. Why is the clinical history suspect TB? We just go back to the MRI.
So I see this one now. This was it, necrotic tissue. I don't know how the agree is. In giant cell tumors, no? You see a fibrous or solid equators. Here, this is, for me, it looked like a necrotic area. That abscess or a pus, thick pus, okay. I don't know, my radiology police will agree. Doesn't look normal like fibrous tissue component. But contrast they are given now. One periphery is analysis. Full analysis करता. Is because look fourth case it will go with Nancy. Because are
Maybe you said Leonard. So first way in the first row, the
come that come. So you'll see up but key to sort the regular James Kimoda pressure the regular inorpel. This is like this extending in irregularly in the MRI of T1 also. What T1 out? T1 also very irregular thing. It did look like this, no? For example, fuzzy. In Jane cell, you're seeing the MRI, the Euro transition. It did look very typical like a Jane cell. Thinking more of the, for me, that as soon as I saw it, more necrotic abscess kind of a thing, which was with the bad. See, the TB was one of the best diagnoses, abscesses.
in list. Then a review and second opinion was taken for the same histopathological slide. Even this one suggests of extensive necrosis, the tilcom granuloma, and even this says negative for Barry-Pittsy. That curious. You lost this?
We see convex tissue nearby. Shake is insisted. The articulation tissue, because we always see that in like another ambulatory. So when we do spine operate, you get confused whether it's a disc in preference or it is a convex tissue which is coming out and copying out the nerve. Is there any sequence of something we differentiate between a granulation tissue or a fat or a edema?
No, generally, caseous material, thick caseous material, equating caseous material, you can differentiate that from a fibrous operate. Hypertrophy, fibrous operate and the food thing. I think you can differentiate on the body. I have a suspicion.
It's very good. So, as we can see the essence. It's because she says, we see what's Erika Radhan's message suggests. The Erika Radhan's shows us the anticipation.
Also, in this well-contained lesion, if pain is there, unlike you could DCT, this key only when it is microfracture is happening, is in pressure on the cortex, then only there is some signs of fraction or pain. If there is a pain with a well-contained lesion, generally not towards case of tumor. It is something else. More, it's well-contained, product lesion, more towards infection.
So what did you get on biopsy? What was the cross you hit? So
it's tender. Around many blood issues. Because DCT is definitely not GCR. It's Ross Fred itself. But the red was Arbara. There's a white of face. So what do you do next? So we entered that Kirotach.
We taken up all the HS like protein really with the slight texture like that. And this is the post of X, right?
You feel the
Very not. This is a post op alias. No alekop, no other pap, no moles may get code.
of course talk JDT.
Oh, I did.
Because the arches were here and there was no structural fit was not there. So which is spirited and left it open. You put any current body let's go on again retros and it will fit with it to there.
These are the follow-up X-rays.
Lalo cap
Defected doctor so. And she's doing totally fine. He had all the limits. Our mobility status. He no residual complaints or deformity or ESB.
Thank you for your testing because the coordinators. The radiologist and the MRI notes. And they know the diagnosis. How to put that MRI sequence as a TD now. Because Sir told in the beginning that if for intense reasons or not CAT. If concussion as.
That voice the cervix, he has already mentioned that DB can present.
So basically we aren't honest as a clinician me particularly I'm not worried about your diagnosis. MRI, adults, I'm not expecting a diagnosis from adults, personally. We want description of the digit. So orthopedic surgeons, no, they don't study MRS. They not understand hyperintense. This is, we're not teaching, and obviously, if you start describing that, then there's a learning.
What is happening in the whole BB plus correct?
Describe that. And then correlate again because of these bitches, this could be this. That's what we want to know. Anyway, perhaps it's a must. So that Fedway help us. You can always put a different diagnosis. Like they put behavioral patterns, broke those. Yes. First, they are not wrong actually. They give a print.
And is this typical finance haptic?
It just depends. I say if part clinical diagnosis initially as well with your
Was is it dangerous in taking info?
I tell you, X-ray showed thick sclerotic margin. So it is unlikely to be GCT. Some probably more infected. X-ray will be more infected. MRI, like I told you, like a leconic cape. So top like a solid copper associated chains. So I was more towards two opposites.
Sets, compastrants.
Was an so there be some sort of coagulation tissue, soft tissue, sclerotic area,
Or of lab, basically. So much enhancement they are not see. The whole thing was enhanced there. Like a solid car. I don't know this is about Ben Rojas. Usually bone tumor is like that. It's not more of an abscess. What was that? What you saw there in theory? You saw solid tissues are there.
so why Kish is a the surface will be not thick granular tissue was there. Kish is fibrous tissue. Spiky fibrous tissue. She curated it all.
So the peripheral wall is enhancing bone
different one aspect there was.
walls.
Actually, like so, look at the lateral part of the X-ray, lateral cortex. See the lateral cortex thickening. So it's that mesh thickening of the binashura thickening. So you keep the relations. No, we don't expect to go for the diagnosis on MRI. So that's very if you got any
Well, there was no posterior steps.
But I like the Isabel's report, Claire's report, because they had given all the options. If what happens, such a no, you tell one particular thing, oh, they different now. Biased, extremely biased.
So